I'm both MD and PhD in terms of my degrees. My title is I am the president of Mayo Clinic Labs or Laboratories, and also the chair of the Department of Laboratory Medicine and Pathology at Mayo Clinic. Regarding the state of testing, because of my role as president of Mayo Clinic Labs, I've actually have been helping with the national response to COVID testing since the early days of the pandemic. Was part of a team that met with the Pence team at the White House in the first week of March of this year, and since that point in time have been very much focused on increasing the scale of in-laboratory testing available for the diagnosis of COVID-19, both for our Mayo Clinic patients and nationally as well. In terms of the current state of testing, I think that we have seen a dramatic response from both academic and private laboratories in increasing COVID testing capacity in this country to the point where we can now do 1.5 million tests per day. But we have seen with the current surge in cases that even with that, extremely impressive national testing capacity that we need, the need for COVID diagnostics for managing the pandemic is going to be with us for some time. So I think the state of testing is such that we have sufficient capacity at this moment to meet the country's needs, but we're going to have to look ahead into the rest of this year and into 2021 in providing both in-lab testing as well as point-of-care testing or at-home testing to manage the pandemic, as well as having the good tools available to guide either the use of therapies like monoclonal antibodies or convalescent plasma and eventually vaccines. So I think the state of testing is one where we have made great strides, but there's still work to be done in terms of using the clinical laboratory to manage the pandemic and to help us get through this.
All right. Do you have any statistics you can share with us in terms of our capacity now compared to the Mayo Clinic laboratory capacity, say in like March and April? And then also, I'd be interested if you could just share some overall like positivity rates, what we're seeing in the areas that we serve.
Sure. So we actually knew of the coming of the SARS-CoV-2 virus, to our country. We were aware of this back in January, that this was a growing concern in China because of our partnership with WuXi Diagnostics, which is a joint venture between Mayo Clinic and WuXi to provide laboratory testing to Chinese patients. And through that partnership, we were aware of the pandemic or the at that point, I guess it wasn't a pandemic, but we were aware of COVID-19 and the SARS-CoV-2 virus, and had actually started to develop our own laboratory developed test in anticipation that we were going to need that for our practice. That was in February. So in the early March, we did receive EUA approval for our own test, as well as worked with Roche as our first major commercial vendor to grow that platform. So in the early days of March, we had capacity of a few thousand tests per day. To where we are now today, I think we've had up to 9 different testing platforms at any one point in time that we have been using in our institution for COVID testing. And on our Rochester campus, we can now provide about 20,000 tests per day. We also have testing capabilities in Florida and Arizona, as well as in the health system. In terms of positivity rates, we up until I would say the last 6 weeks, our positivity rates had been less than 10% for the majority of our sites. We had some outbreaks in southern Minnesota that had seen positivity rates climb above 10%. But in the last month or so, we have been seeing in the Midwest, the positivity rates ranging anywhere from around 10% on our Rochester campus to 20 and even 30% in some of our Wisconsin facilities, particularly in Northwest Wisconsin and Eau Claire. So it changes day by day, and I'm sure Suzanne or Ginger can get you the statistics, but unfortunately, we have been running above 10%, around 10% or slightly higher in the Rochester campus, and 20% or higher in Wisconsin and also in southern Minnesota outside of Rochester.
All right, great, thank you. So if you want to start putting your questions in the chat, that would be great. And then in the meantime, Dr. Maurice, could you also speak to just run through the different types of tests, what they're for, and maybe any new tests on the market now, and pros and cons, how they're used, who should be tested, just kind of the basics.
Sure. So I really and when you look at the clinical laboratory for the managing of COVID-19, there's really three classes of tests, I would say. There are those that are used for the detection of the virus itself, the diagnostic test. There are tests that are used to identify who's been exposed to COVID and has managed or mounted an immune response, I should say. And then the third class are really the tests that are used for COVID-19 patients to try and identify those who are at risk of getting really sick with the disease, because that's really what we're trying to manage here is our patients that are getting severely ill and giving them appropriate care. So we also have tests that were now developed to identify which those patients might be before they get sick so we can intervene early. In terms of the diagnostic tests, there are two basic ways to approach that to detect the virus. One is to look for the nucleic acids of the virus, the nucleic acid amplification tests, of which PCR is probably the most talked about. The other is to detect proteins made by the virus, which are the antigen tests. Each of those different approaches have different strengths and weaknesses. The nucleic acid tests tend to be more specific for the virus itself and likely more sensitive as well, depending on the approach that's used. The challenge with those is they don't lend themselves as well to point of care testing. The flip side is the antigen testing. That is something that can be used in a variety of different settings, including the lateral flow testing, which is basically like the home pregnancy test, that type of technology where it's a strip of paper that can read a positive or a negative. But again, they might not have the same sensitivity or specificity. So there's a lot of work still to be done, a lot of confusion there. The test for who's been exposed to the virus still is predominantly a blood test to look for the antibodies that a person makes in response to the SARS-CoV-2 virus, the so-called serologic test. But there are others as well that are looking now specifically at the cellular level of the immune response, at the T and B cell level as well.
All right, thank you. So my internet just went out for part of that, which means I lost everything in the chat. So the first thing I see here is a question from Sasha with ABC News. If you have submitted a question to me or to the group prior to that, could you please repost it? And we'll start with this question from Sasha with ABC News. To start, I would like to focus on the recently authorized Lucira at-home rapid tests. Clearly, if tests like these are effective, they could be a great pressure valve reliever for the already strained diagnostics infrastructure. However, could you speak to some of the concerns about that, lessen specificity and sensitivity, and especially introduce human error with an at-home test, even with a prescription?
Yeah, excellent questions. So the Lucira test, which was announced, given EUA approval, I think late last week or mid last week, is a nucleic acid amplification test. It is not PCR. It's a different method called LAMP, or loop mediated amplification, which is highly technical. The advantage of that is that it doesn't require the same kind of specialized equipment. For PCR, actually, you have to go through multiple heating and cooling cycles, which really does not lend itself to a home use test. Whereas this is a test, that method that can be read at home, and it has basically a colorimetric output, meaning it changes color if it's positive. So there is concern around that methodology, this alternate method, that it might not have the same specificity of PCR, but actually it looks like it works quite well. And so again, to remind people, the specificity of a test means if a test is positive, how likely is it that that person actually has the SARS-CoV-2 virus? So what, a high specificity test means that a positive is always associated with the virus, or almost always, whereas a lower specificity would mean that there is some potential for a false positive or a positive in a person that doesn't have it. Whereas sensitivity is, if I have the virus, how likely is the test to be positive? And so 100% sensitive, meaning everyone who has the virus will have a positive test. And there is no 100% sensitive test on the market, nor 100% specific for that matter. The method from Lucira does have a high sensitivity and seems to have a reasonably high specificity from what we can tell what has been published as well. Of course, the challenge with all of these tests is that once they get out into public use, we learn more about their performance characteristics, and sometimes those things change. Particularly, there are differences in testing symptomatic individuals with COVID versus those who are asymptomatic, because typically asymptomatics are more difficult to test for, both in terms of sensitivity and specificity. The other challenge, the beauty of the test that has been, or the advantage, I should say, of the test that has been from Lucira, is that it is a straightforward diagnosis, is a straightforward interpretation. Some of the other antigen tests that are the lateral flow tests, those have to be self-read for a line, and for any of you have looked at some of these home self-read tests, those can have reader errors as well. A lot of the false positivity rates that we were hearing about with the Binax now from Abbott, for instance, was related to potentially misinterpreting, because you have a very specific time you need to look at those to interpret them. And then in terms of the other concerns, really are, number one, how quickly we can make these tests. Although the Lucira test has received EUA, it appears that probably there won't be in widespread distribution for another few months at least, because the supply chain has to be geared up to make these tests. And the last but not least is, how do we make sure that the information makes it into an individual's medical record for these tests that are done at home, if the results are going to be used for tracking the virus or for making healthcare decisions for that individual.
Thank you. I'm just going to throw in a follow-up question from that same reporter, Sasha from ABC News. She says, even though it is not supposed to be used as an asymptomatic screening, what concerns are there that people could use it as a kind of carte blanche?
Well, I mean, that's again the challenge with these is they are, even when they're released for specific intent or purpose or intended use, if they are available for home use, they will be used beyond that, and then that will cause challenges in how the results are interpreted. Because if the test, particularly if they're not ordered by a physician or cleared by a physician, so they can just be ordered and done by the individual, that they might not understand some of the implications of a positive or negative test, because there are nuances around that, particularly for what the test was designed to be used for versus how it's being used by an individual that's running the test.
All right, great. Thank you. This is from Megan in Mankato. Do you have any updates on the shortage of beds or staff locally? Mankato reached capacity last week and patients were being sent to Rochester if needed. And if you can't answer that, Dr. Maurice, I can certainly ask Amanda to follow up with this reporter on that question, unless you want to speak to it.
Sure, I can speak to it, and then maybe there could be follow-up information as well. I think it's important for people to remember that the intervening period between when we first learned about the pandemic in March and early April, and where we are today from a healthcare perspective we're in a much better space. So yes, we have seen a rise in cases, and yes, we have seen some capacity constraints on the hospitals. The converse of that, of course, is that we are much better prepared. If this would have been 8 months ago, it would be a much more dire situation. And there are things being done throughout the Mayo Clinic health system here in the Midwest to manage capacity throughout, so that Rochester can serve as a backstop for those hospitals in Mankato and Eau Claire and La Crosse, Albert Lee, that might reach capacity. So we're working together. We have systems in place, and we continue to innovate to find ways to keep patients out of the hospital. Working on outpatient transfusion centers, for instance, where patients can get treated. when patients are treated with remdesivir, for instance, it's a 5-day course of intravenous treatment. Typically, patients are better or feeling better by the second day. So it's possible now that potentially we could let some of those patients go home and complete their treatment in an outpatient basis. So lots of things are happening. I think that Ginger and Suzanne can give you the most up-to-date numbers. Right now, we are we are still able to manage the patients that are coming in, but it's through the great work and preparations of the practice to be ready for something like this.
Okay, thank you. So a similar question from David Leclerc in Eau Claire. David, I'm going to ask you to follow up with the public affairs team in La Crosse to get specific data about your area. Eau Claire and La Crosse, you said. So if you could follow up, they can give you specifics on your area. Okay, next question from John Mulseed. What are the challenges with the availability of reagents and kits for testing, such as the Roche Cobas 6800 and 8800? Are you expecting that to continue to limit the use of these systems, and if so, for how long?
Well, thankfully, we're actually in a much better place through coordinated efforts between the companies like Roche and Thermo Fisher and PerkinElmer, the laboratories, and with the assistance of Admiral Giroir and the federal task force. We do have much greater supply of the reagents for the in-laboratory testing than we did even earlier in the summer. So far, we have been able to manage that. To manage the demand on our labs without falling behind. There is, of course, always concern when we're doing that many tests in a day, 1.5 million tests a day that we're running on average. And the ACLA, the public labs, of which Mayo Clinic Labs is a part, ACLA are running over 500,000 tests per day. So far we have all the reagents and plastics and things that we need to be able to continue to offer testing at that volume. We just keep a close eye and work in close collaboration across the industry to make sure that remains the case, just because it is putting a strain on the system to be sure to have to be running this many tests.
All right, thank you. This question comes from Tanner at WDAY in Fargo. With the popularity of saliva testing in Moorhead, and with some of that having the capability of being done at home, would you believe that would drive more people to test that way at home? If so, is it more of a benefit for asymptomatic people or symptomatic people?
Well, one of the real benefits of getting the testing at home is that particularly if it's someone that's symptomatic, first of all, it's not only more convenient for the individual, it also prevents them from going outside the home and potentially exposing others to COVID if they do in fact have it. So there's great benefit for at-home testing for symptomatic individuals, both for them and for the healthcare system. But it's important there that if they are symptomatic and if they're positive, that they get follow-up with their provider to make sure that if they need more care, more intense care, that they get that care from their provider. For asymptomatics, there's also a great advantage in terms of we know that 50 to 80% of the transmission of this virus is spread by asymptomatic individuals. So identifying those without symptoms, but that are in fact infected with the virus remains very important. So at-home testing could be a very even more effective in terms of preventing the spread by letting people know that they have it, even if they're not aware of it, so they can take the appropriate measures. That's where, of course, the challenge there is that is the more difficult scenario to be testing for the virus in terms of its detection. So that's why we continue to have to look at the performance of these tests and evaluate them as they're deployed to make sure they're doing the things that we need them to do for us. Saliva is another example. That's a specimen type that great strides have been made in terms of understanding if it's useful. It does appear that it is a good specimen source for detecting SARS-CoV-2, which was not known even earlier in the summer. It does certainly lend itself to easier at-home collection. The nasopharyngeal swab, which is the most sensitive specimen, clearly, if those of you have seen them, that is something that just can't really be self-administered. So having these self-administered tools for getting a specimen for COVID is really very, very helpful. Saliva is one. Another one that Mayo has been working on is the Mid-Turbine nasal swab, which does not go nearly as far back. It goes into the nose, but not nearly as far back, so it can be self-administered. because the balance is we want to make sure that the specimens if they're easier to collect, but they're also not really where the virus is living in your body and therefore less sensitive, is a trade-off we have to watch against. And that's why Mayo has not been using some of the alternative specimen types, like the anterior nasal swab, just in the nostril, appears to not harbor a great deal of the virus, and therefore a negative result doesn't tell you that much. So that's where we've been trying to strike the balance there.
All right, thank you. This one came in, someone texted me this one. So what would you say to viewers, listeners, readers of these reports from this session who are planning on using testing to make decisions about their Thanksgiving plans? So I've heard some people say, I'm going to get a test and then I'm going to have my family over for Thanksgiving. What would you say? What is the pitfall of that kind of approach?
Well, the one thing I would say is that unfortunately, we don't have any single test available that can give someone, a stamp of approval, if you will, that they do not have SARS-CoV-2 virus. There is no 100% sensitive test out there. So unfortunately, while a negative test might give you some reassurance that you don't have the virus, it can't be used to consider yourself scot-free, if you will, or free and clear of the virus. So I would think, number one, just to be mindful on the Thanksgiving holiday about having gatherings, particularly if there's individuals in your family or in your close circle that might be at risk for more severe illness with COVID, like those with underlying health conditions. And that if you use testing, that you understand what it can and can't tell you, it might give you some measure of security that you're not going to be exposing people, but you still have to mask and socially distance and do those things if you want to be sure that you're not going to be spreading the virus, even if you had a negative test.
All right, great, thank you. So just a note for journalists, some of you are submitting questions in the chat that are specific to a location. I'm going to ask you to submit those to newsbureau@mayo.edu. Dr. Maurice is a very smart guy, but I'm pretty sure he doesn't have stats memorized from every region that he serves. So we're going to let him off the hook for that. Here is a question that does have some elements of a regional specificity, but there are some other things that you could perhaps address. So this comes from Barron, Wisconsin. As you know, we are wondering how test results are tabulated and shared. Is a percentage of positive tests available from Mayo Northland campus? Well, we can get back to you on that, Robert. And then he says, we're also aware that the National Guard has set up testing in Barron. So we're wondering if the need for testing exceeds capacity in that part of the state in Wisconsin.
So, in terms of the reporting, they're actually, for all the COVID testing, one of the things that we have had to do is build the electronic interfaces from the tests. From the test to a variety of different health agencies, both at the federal and state level, including the state of Wisconsin. So we do transmit those results so they can be distributed and used for public health purposes. The collection centers, and we've done the same in Minnesota, where working with the Minnesota Department of Health to set up collection sites, sometimes using the National Guard as well. That is one of the main bottlenecks right now, is actually individuals having access to a facility where they can have a test performed, a specimen obtained, I should say. To date, we have been able to have sufficient capacity to run the tests within 48 hours of their receipt. I mean, that's really the goal here, is to get the testing done as quickly as possible. So we have been able to stay on top of that. And if it is, I'm not sure about the Barron facility in the National Guard, but if it is supported by Mayo Clinic labs, what we do is we actually, if the local capacity for testing is exceeded, those tests get routed to Rochester, where we have the high throughput automated machines to run the testing.
All right, great, thank you. This question comes from Tim at Fox 9 in Minneapolis. Dr. Maurice and Mayo Labs were instrumental in developing serology tests last spring to test for immunity. The emphasis at the moment seems to be more on PCR tests. The question is, going forward, as more people get exposed to the virus, is the serology test going to be more important to allow people to return to work and school?
Well, it's interesting. The serology test will be of growing importance, and I think for two reasons. Number one is to understand who's been exposed to the virus and mounted an immune response, and how prevalent has the virus been in any community. It will probably also be helpful in terms of vaccine distribution, understanding who might need to be vaccinated when those vaccines are in limited supply. In terms of the root of your question, though, is, can the antibody serologic test be used to give someone, if you will, an immunity passport, which is one of the terms that's been used to say, well, this person's immune to COVID. That is still yet to be determined. Even with the vaccines that look like they have a high effectiveness, now there's 3. We don't know how long that immunity will last. So I don't know. I think getting serologic testing will be an important part of that, but I don't know yet if we can really say that having a positive antibody test for SARS-CoV-2 is going to be equate with a clean bill of health in terms of catching or spreading the virus.
All right, thank you. Another question from Sasha at ABC. On the issue of staffing shortage, can you elaborate further on Mayo bringing retirees to staff hospitals and redeploying staff? And if you would prefer that we defer that question, we can do that, but I know you're probably aware at a leadership level.
Yeah, sure. I can speak to it. And I think if there's specifics that you need, you certainly can follow up with Ginger or Suzanne. I think a lot of people were taken aback by the report in the press of 900 staff, Mayo Clinic staff, being diagnosed with SARS-CoV-2 recently. That's still, I think for that number, it's important to remember that includes both employees that are working on our campuses as well as those who are working remotely. And actually only equates to about 2% or less, somewhere around 2% of our total employee base here in the upper Midwest. That being said, clearly the concerns are that we have sufficient staff to care for our patients, and the number of patients who have need care for COVID has required that we move staff around, redeploy them, and that's on the lab side as well. So we actually had the redeployment, which we had put into effect earlier in the year. We had allowed some of those individuals to go back to their regular duties, but then we had to ask them to come back and work on COVID testing because of the surge in demand. And it's been the same on the practice side. I could tell you that at Mayo, these are all highly coordinated so that we know who's available to move to different areas, and also understand the impact on other areas of the practice. And I do think that might be included calling back some individuals who have unique skill sets who have retired from Mayo, but who have said they would make themselves available. But I can't speak to the specifics on that. I can tell you amongst our active workforce, we have plans for redeployment of staff to meet the needs of our COVID patients, and those have been in effect.
Yep, and I can share a little bit on the retirees. So we do have retirees who are recent retirees who have maintained their credentials, and some have been called back to do things like man phone lines. We have a COVID phone line for our staff as well as for our patients. So they're doing activities like that so they can free up those nurses for patient care activities. So that's what we're doing there. Clarification on the 900 staff, just so everybody knows, once they do test positive, they are not still at work. I can promise you that. And let's see here.
Yeah, and I think the important thing, Ginger, there to emphasize is that for all of those individuals, we have an occupational health workforce that examines those cases to determine if it was community acquired or at work acquired. It appears that over 90% of those are being acquired in the community. So again, it's a reflection of the activity of the virus in our community. And the other thing is just to really reassure patients that it's still safe to come to our campuses for care. We are taking every measure to make sure that's the case.
Yep. Less likely to get it as a patient than you are in the community.
Yeah. Indeed.
Okay, a question from Tanner. If it's an at-home test, does that mean that people would possibly wait longer for results, or does it take about the same time?
So it depends on the at-home. So the at-home collected tests, which are sent in the mail, still are going to have the same around the same turnaround time as for something that's done at one of the testing collection sites. So because it will still be sent into the lab and be run in the lab, and then the results returned back to the individual. Of course, that's why there's such a interest in these at-home tests that can actually be read at home, like the Lucira test and like some of the antigen tests as well. But those really have to go through, and it's important because someone asked earlier about the individuals reading these and individual variability, and that is actually part of the FDA EUA process. They will look at the ability, how easy these things are to interpret, essentially, that a layperson could do it. So, but that is, and we do know in terms of preventing the spread of the virus that the sooner someone knows that they have SARS-CoV-2, the much more likely they are to do something in terms of protecting those around them. So that's why the other real interest in at-home, actually self-read tests, is that if you can get a result within 15 minutes, you're much more likely to act on it appropriately versus if you have to wait a couple days after an exposure, for instance.
All right, great. Thank you. This comes from John Mulseed. What are you testing for to determine if someone is likely to experience a severe reaction and/or symptoms to the virus?
So basically, what you can do, so a lot of the illness with SARS-CoV-2, there's really two things that go on. Number one is, of course, the virus itself and where it infects individuals, and it goes down. It starts in the upper airways, and it can go down into the lower. It does go down to lower respiratory tract, and it appears it maybe even can affect the cells that line our blood vessels. But a lot of the illness that we see in these severely ill patients is not just from the virus itself, but actually our body's response to the virus. So our immune system basically has to be activated to eradicate the virus, and not just the virus, but our own cells that are infected by the virus. It does appear that many of the individuals who get severely ill and need life support with COVID-19, that's because of their body's response to the virus. So what the test that we have now looks at, there's the way that looks at blood levels of different essentially hormones, if you will, that are used in the immune system, like called cytokines. So we look at the cytokines, we look at blood markers of inflammation, essentially. And if we can see, even if patients are not doing poorly, if they have very high levels of some of these, that is a harbinger that they might get in trouble, and therefore will allow us to get them triaged for the appropriate care. But this is a new test. It was a test that we developed since April, and just recently became available here in the last month or so. And Suzanne can get you the specifics on those dates. But it's a newly available test that we're now using and to help manage and understand which patients are going to need more intensive levels of care.
All right, thank you. Dr. Maurice, we are close to commencing administration of vaccines. What kind of an impact will viable vaccines in use have on testing and the demand for testing? Can we expect to see a high demand for testing well into 2021?
I think the answer to that is yes. We will see a continued high demand for testing into 2021. And that first and foremost, because the vaccines themselves will take, now that it appears that they will be we'll have vaccines that have EUA approval. So the first two steps of any vaccine being widely deployed have been met in terms of proving that it works and getting approval. We now need to get those vaccines produced and distributed, and then we have to have a public willing to take them. So it's going to take a period of time for those vaccines to be rolled out and available. And in that interim, we're going to have to continue to test and manage the spread of the virus, just as we have seen. And also, I think we'll be using testing to identify those who are at risk and those who are most in need of vaccination. So because there'll be prioritization schemes for which individuals need the earlier vaccination, healthcare workers, those particularly at risk for severe disease. And so continued testing will help us understand where the virus is most active, and therefore where we need to be focusing both our treatments and our vaccines.
All right, great. This one comes from Tim at Fox 9 in Minneapolis. Follow up on self-read tests at home. If they are so potentially important, is Mayo developing one to compete or complement with the Lucira home kit?
So we don't really manufacture diagnostics in that way. One thing that we are working on is the Mid-Turbine nasal swab, which I mentioned before, is one that we have developed and actually can, working in collaboration with Dr. Jay Morris in our radiology department, we can actually 3D print and produce our own Mid-Turbine nasal swabs. Those, we are working with FDA to get those approved for home self-collection. So we are doing that to make sure the testing capability we have here at Mayo Clinic Labs can be used for individuals at home, because clearly just an at-home test that's self-read, it will have a role, but will still have a role for home collected, high accuracy in-lab tests. So that's what we're working on. And then we were then collaborating with other companies to look at their solutions for point of care testing, and in particular at this point, so point of care meaning right there at the individual spot, which I guess could be at home eventually. So we are working with outside companies to understand what they have available, and also to help them understand the performance of their tests and compare and how they compare to the what are considered the gold standard tests like the in-lab PCR.
All right, great, thank you. All right, so I don't have any more questions in the chat at this time. So I would invite journalists, if you would like, you can unmute yourselves and ask a question directly to Dr. Maurice. Or you can submit it in the chat.
And I just want to, oh, go ahead. Sorry.
Oh, I apologize. Yeah, thank you so much, Doctor. I appreciate your time today. I'm Carla Holt with Care 11, the NBC affiliate in Minneapolis, and I just wanted to check in regarding the new tests. What exactly is new and different about that? I'm just struggling to translate some of the medicalese, to be completely honest, and making sure that I can deliver the most accurate information to our community regarding what is this new test exactly doing that is different from what we have been able to experience and how we've been serving the community up to this point? Thank you again.
So just a clarifying question, which new test in particular are you interested in?
I think as I understand it, you've been reviewing two of them, this at-home saliva, and then also the one that further determines a person's susceptibility to the disease and how they will respond to it. Is that correct? And in which case, I guess, a general clarification of both of them.
Sure. So I think that for just to clarify, for at-home testing, there are two options. Essentially, there's home collection, with then sending that of a specimen, and then sending that specimen to a centralized laboratory where they will perform the testing for the virus itself, and then give the result back to the individual. That's the saliva test, including the one that's available in the state of Minnesota, I think through Fault Health in collaboration with the Minnesota Department of Health. So that's that class of tests. What we're now just starting to see are the emergence, and the Lucera is the first of an actual at-home test where an individual will collect a specimen at home, actually run the testing at home and get a result at home without having to put it in the mail. Those are just coming now, and I think we'll see more of those coming into 2021. And the other test that we have that I discussed is a Mayo Clinic developed test in our laboratories, and that is a test that looks at blood levels. Basically, it's a blood test for if we have an individual that's in our hospital that presents and is diagnosed with COVID-19, we now have a blood test that can help identify if that individual is showing markers of inflammation, which would be worrisome for their development of much more severe disease, so we can intervene early. So that's basically a blood test to look at someone's response to the virus to see if it's indicative that they're going to be at risk of getting really, really sick.
And that's currently available, or that will go online on what date again?
No, that's currently available. You can. I think Suzanne would have the specific date. It is very new. We just, typically it takes us a year to 18 months to develop a new test. These are tests that we have developed in the course of 6 to 8 months. So it is available, and it did go live, I think, in the month of November. So it's just one that is just coming online now.
Thank you.
Morris, Hi, Dr. Morris. This is Sasha with ABC again. Thanks so much for fielding my many questions. This one I have sort of more generally about the diagnostics industry that's quite strapped right now, as we know. And as you said, that there is sufficient capacity in terms of processing the test, but manpower is also an issue. And this morning, Quest issued one of their bulletins that was essentially a warning, asking their patients and their clients to limit COVID molecular testing to symptomatic and recently exposed patients, and that they're expecting turnaround times to increase due to the surge, especially around Thanksgiving. I'm wondering if you could speak to that kind of as a whole. What we're seeing in terms of demand, especially, you spoke to this a little bit in terms of Thanksgiving, but how concerned are you that we're going to be able to meet the demand, especially in coming months?
Well, I just wanted to start off. I want to apologize for everyone for being a little bit late joining you this morning or this afternoon if you're in a different part of the country. So I just want to say, because I want to be respectful of your time as well. In terms of the capacity, look, we have been focused really since, and Steve Ruskowski from Quest, and Adam Schechter from LabCorp, all of us were there at the White House in the first week of March, making this commitment to increase our testing capacity, and we have been heavily invested in doing that. But the reality is that there's nothing that's limitless, and so we have to. It reaches a certain point that where even 500,000 tests in a day can be overwhelmed in a country of 330 million people. So we continue to take measures to try and to respond to the need, but at some point the demand will quite simply outpace the capacity, and so that's why we're really trying to be mindful to make sure that the biggest concern is, really there are, I would say, kind of three groups of people that are interested in getting testing right now. There's those or need testing or might ask for testing is probably the best way to put it. There's those who are sick who need to know if they have COVID, which of course are the highest priority, right? As we still want to take the best care of these patients. There are those who have a known high risk exposure or are otherwise potentially high probability of having asymptomatic. So they're asymptomatic, but for some reason we believe they might have COVID. Those are really important, or at risk for developing COVID, like high risk exposures, either at work or socially. And then the third group are those who are, this is the biggest travel week of the year. And there's those who, as the earlier question alluded to, just want some peace of mind as they travel, that they don't have SARS-CoV-2. I think as we walk back in the ideal setting, because of the proclivity for SARS-CoV-2 to be spread by asymptomatic individuals, that we would have enough testing to just for any particular use, because we want to find those who have it and don't know it. The reality is that when we have a very high demand like this because of the spread of cases, we have to walk back from that to say, well, the most important are those who are sick with the illness, potentially sick with the illness, so we can identify them and treat them appropriately. So and I think that's really what the call from the industry right now is to have some, and particularly have some. So just the need to have that prioritization to make sure the testing is really available for those who need it. And I think that's why Mayo Clinic is really, supportive of efforts to reduce potential exposures here over the holidays, because the number of people who are exposed, not only did the number of ill individuals go up, but those who have high risk exposure in that second group go up. So basically increases the demand on testing. So right now it's something we've been keeping an eye on. We've been working across industry to stay on top of, but the concern is that there is a fixed rate of testing, even though it's extraordinarily high, above which then there starts to create backlogs, because there's just not sufficient capacity to run all the testing that's being ordered.
When do you expect maybe some of these capacity issues to be resolved? I know it takes generally a year for manufacturers of some of the plastics and reagents used in some of these tests to even get FDA approval, but things are moving a lot faster. You talked about the blood test. This happened in a span of 6 months, not 18.
Yeah, I think the next relief and constraint on testing probably will be more in the antigen testing, which we talked about earlier, particularly the lateral flow, the paper card-based antigen tests. like the Binax now. There is a global effort underway to increase the capacity or the production of these tests. I've also been involved with an industry advisory group for the World Economic Forum that's supporting the access to COVID diagnostics globally as a global health issue, particularly in low and middle income countries. And I can tell you through that work, I am familiar with large-scale global efforts to increase the production of antigen tests. So I think going into 2021, ideally what we'll see are much more deployed of these sort of antigen and other rapid point-of-care tests, which are then backed up by the lab capacity, understanding that those tests may have some performance differences to the gold standard. We need to understand what they can and can't do, and then they'll become a very important part of our testing paradigm, backed up by the in-lab capacity that's been by Mayo Clinic Labs, Quest, and others. So I think that's probably the direction that we're headed. There certainly can be more and more production of the centralized testing as well, but I think we'll see some of that, but much more deployment of point of care type testing to help provide the testing needs for the country.
All right, thank you, Dr. Maurice. Other questions from others or anyone?
Yes, this is David LeClaire from WEAU 13 at our La Crosse Bureau. Again, Doctor, you were saying about the home testing. How are you looking to see? Just so I have a reminder here, when you're looking to have that testing, like the saliva and the lacera, more readily available, how are you looking to make that? See about that being more readily available in the next few months?
Well, for our Mayo Clinic, for our Mayo Clinic practice, we have been working with these industries, and the company we have worked with most directly is Q Health, which has a point of care test, which can be done. It's still done by a healthcare provider, but can be done point of care. Just honestly, the supply chain constraints now are focused on the point of care testing, which really has to ramp up, just like we ramped up the in-lab testing capacity. So what we have been doing is we actually, going back for 6 months or more, have been working with these companies to to help them validate their methods if needed, and validate their testing, and then also secure the volumes that we need to help care for our patients. We really are not directly involved with any of the companies that are doing the at-home testing, so we're just keeping an eye on that and working with in this case, the Minnesota Department of Health and others to understand how that testing fits into a broader system of COVID testing for the state and the country.
Okay, thank you. I appreciate it.
All right, we have about 3 minutes left. Any other questions? Last call for questions. Anyone? All right. Well, I think we have met all the questions. So once again, if there was something you asked about or wanted to ask about that was like related to hospital capacity and in the Mayo system or anything like that, feel free to send us an email, newsbureau@mayo.edu. Also, just to note, Dr. Amy Williams, the Executive Dean of Mayo Clinic Practice, will be giving a situation update tomorrow. If you would like an invitation to that, it's a Zoom briefing like this one. Also, newsbureau@mayo.edu, and we can get that invitation to you. And with that, I think we will call it a day. Thank you so much, Dr. Maurice. I really appreciate your time. And thank you, journalists, for attending. Appreciate you joining. Stay safe. Anything else, Dr. Maurice?
No, just thank you. And I wish everyone a happy Thanksgiving and stay safe. And if there's follow-up questions, please let Ginger and Suzanne know, and I'll do what I can to get to them.
All right. Thanks so much.
Thanks, Dr. Maurice.
Thanks, everybody.